Joining us this morning to talk a little bit about the situation at San Juan Regional Medical Center and some other thoughts about what is going on with COVID-19. Dr. Robert Underwood is joining us on the telephone this morning, the Chief Medical Officer at San Juan Regional Medical Center. Dr. Underwood, welcome back to KSJE. It's great to have you with us.
Thanks, Scott. Thanks, Megan. Glad to be on.
Thank you very much. Well, let's get started by talking a little bit about what the governor was talking about earlier in the week, and that was this idea that our hospitals are getting to that maximum capacity. And so she was going to be, I think, talking about a process where care could be then rationed around the state because just the beds are running out. And so I guess two-part question. Are we in danger of that happening here, Dr. Underwood? And I guess what would the procedure then be if and when you have to implement something like that, a triage type situation?
So it's a multifaceted, really kind of question, Scott. I would say that this is something that and we call it crisis standards of care. It is a known term in the world of incident command and disaster management. A lot of times people think of crisis standards of care around a hurricane or some other natural disaster. You know, clearly this is on a little bit of a different level, but these are contingency plans that we actually already have worked through in terms of modeling, et cetera. So it's a number of things that are considered, and we don't know if and when we're going to get to that position, but we have plans that are in line, and and we work with folks at the state level to talk about what's happening. That's one of the beauties that I have seen in New Mexico that I don't see at other places, is that we work really hard to cross level. In other words, if you remember in the spring, we were having a very big surge of patients, and other areas were not seeing that, and we were able to transfer patients around to keep us out of crisis level of care. The question is the entire state going to experience this at the same time, and then do we have to get into some level of crisis standards of care? Now, when she talks about that, and when you hear about it, generally you're saying that you're running out of the capability to treat all of the patients that are coming into your facility in one way or another. Now, does that mean number of beds? We have a backup plan for that in terms of where we would put beds, doubling up rooms. All of the rooms at our hospital are private rooms, but do we have the capacity to put 2 beds in a room? The answer is yes, we do. So that's a contingency plan that we would have. The other is around medications. And so we're actually starting to have been working on, okay, if there's not enough of this kind of medication, what is a reasonable substitute, and how do we go about an auto substitution of one medication for another based on what the pharmacy supply is? Others that everybody is concerned about is, what if we run out of ICU beds? And the intent is, and we have a great capacity, we've already exercised it once last week just because we started to get more patients. We have essentially 14 licensed ICU beds at this hospital. We turned our mid-range beds, what we call PCU beds, into ICU beds already. So we've already moved from 14 to 23, and our cardiology floor, which is the 5th floor of the hospital, at the other end from where labor and delivery is, those beds are capable of high-end monitoring, and all of those rooms are capable of being turned into ICU beds as well. And we actually have put a couple of people in that contingency area. We haven't had to ration or limit or anything else so far at our hospital. And it's a continuum, and that's why I say that it's not like, okay, we're here and we pull the trigger and then it's a free-for-all. That's not at all the case. This is a very systematic way that we look at what are our capabilities and in what areas, and how do we transition kind of from one phase to another. Already, and we're not at crisis, but we are at contingency. So our staffing ratios, for example, are different than they would be if we were under normal circumstances. Nurses and CNAs, nurse assistants on the floors, may be taking care of more patients than they would normally take care of under normal circumstances because we are being expanded and we are being stretched. All of those things are taken into account. We also have backup plans. We ordered more ventilators, so we have more ventilators now than we did back in the spring. But we also have the capacity of taking anesthesia machines, if they're not being used in the operating room, and turning those into ventilators. So all of those things are looked at when we talk about them, and we look at, okay, at what time do we phase from one to the next to the next?
Very good. This is very encouraging to hear. The last thing we want is another dystopian nightmare on our hands. I do have a follow-up question regarding the cardiology floor, because obviously since this began, the hospital has been very clear. If you have an emergency, that's not COVID related, don't not come in. If you think you're having a heart attack, get in there. So if you're converting these floors, if you're converting the cardiology floor, where do those patients then go? Is there like another floor that's now mixed and not COVID?
That's correct. Typically, our third floor is, and our third floor is primarily for surgical patients. And we have tiered down our surgical case volumes. So there's room on that floor. We can still move telemetry into those areas so we can continue to monitor those patients. Nephrology, which is for kidney disease, is on the second floor, and we can move patients into those areas as well. So we still have beds available at this facility for sure.
Good to hear, Dr. Underwood. And I wanted to ask you, too, you mentioned about being able to maybe double up some of your beds in some of your patient rooms and if we needed to, adding more capacity and things like that. And then it goes back to staffing. I guess, you're talking about maybe staff that's dealing with more patients than they normally would. Is there a maximum? Is there a time when you have to say we can't add any more beds because our staff just literally can't handle any more patients on a daily basis?
And that gets to where it becomes a state level issue because we look at that staffing capacity as well at all hospitals across the state. There's now a state level kind of central command that looks at who's got what capacity in what areas. So can we move patients over so that we're not stretching any one person too thin? I guess really my point though is that a possibility? Well, certainly it is a possibility. Do I think we're going to get there to where we can say we just can't take anymore? I don't think so. Nonetheless, the patients have to be cared for. And so we will stretch thin. And that's where you get into that crisis level of care. In other words, what do we start to curtail? If we say that, I'll use physicians for an example, that our hospitalists, who are the doctors who typically take care of the COVID patient, that there are more than they can see in a day if everybody is working. Then there are contingency plans to mobilize providers from our community who may work in a private practice now but used to work in a hospital. We have talked to them about potentially coming back to the hospital and working. If we hit crisis standards of care, then there are certain understandings, I guess is the best thing to say, that in that declaration, which does come from the governor's office, that says, okay, the standard of care for which we care for patients is different. And so if we have a physician who's working well outside of what they would normally be doing, then they are protected by the state and covered by the state under kind of a tort claim position, because at that point we're trying to do the best for the most people that we can, and that's really what the focus shifts for. Generally, as clinicians, we think about what am I doing for every single patient to make it the best that I can, and the focus shifts for what do I do for the most people that I can under these circumstances. And it sounds a little squishy, and maybe that's because it is. We can't predict exactly where we're going to hit certain areas. We've started working on the likely things, and I mentioned those earlier: pharmacy, bed capacity, documentation is one of those things. We take relatively copious notes as clinicians in a hospital, but that takes time. And if I can take that time and actually go see a patient and put some orders in, then perhaps my time is better suited there. And then I fall behind on my documentation. I don't document as much as I might otherwise. Things like that are what we consider.
Very good.
Now,
I'm sorry. Go ahead.
I was going to say the last one, and there was in an article in the Albuquerque paper, Dr. Denise Gonzalez is kind of heading up part of it, but we also look at ventilator allocation if we ever got to that point, and we have a series where we look at a scoring mechanism over the survivability potential. If we got to a point where we had more patients that need ventilators than we have ventilators, again, I don't think we're going to get to that point, then we actually have a scoring mechanism that looks at prognosis. And so the people who are most likely to survive would be the ones who would get the ventilator. And that's gone by a scoring mechanism in terms of laboratory studies and lung function and oxygenation, and some other factors are put into that. But it also takes the judgment away in a way so that you don't have the risk of a value judgment. It is really looking at scientifically, these are the best people to put on a vent if we don't have enough of them to go around.
Very good. We hope it doesn't get to that level, of course, but
exactly.
It's good that we have that plan.
Yes. Yeah. So what we are doing in terms of preparation, I loved this analogy that was shared, is remember those big 64 crayon boxes? We're sorting the crayons and getting everything ready and hoping we never get to use them.
Right. That's right. So let's go to the vaccine beat, as I've been calling it, the most recent news. I know that Pfizer is slated to go before the FDA tomorrow, December 10th, which by the time this airs will be today.
There you go.
And I know that you have been, of course, following that closely, and had recently even read the report. So can you give us the scoop there?
You bet. And so there's a lot of technical components of it. And I know, Megan, you said you like to nerd out every once in a while. And this is really, really cool stuff.
Yes.
Yes, it is.
There she goes.
Yeah. So the vaccine comes in 2 doses. We do anticipate that by next week, people have been saying mid-December. Well, guess what? That's next week. That the vaccine would be available. We do expect the FDA to hear this. They've already had the report submitted, and we do feel that relatively quickly after that, they will be issuing an emergency use authorization. We know that we will be getting vaccines in. This vaccine from Pfizer requires a super cold storage capability, and we have the freezer capacity to do that. So we will be kind of the hub of storage within the county area. It is 2 vaccines, one given would be called day 1, and then on day 21, or day 0, and then on day 21 you get a booster vaccine. What's really interesting is that the studies that are showing that even after your first vaccine, about 10 days after the first vaccine, there's a very high level of immunity to the COVID virus. That's after the first one. So by the time you get the second one, your immunity is quite high. Again, they're reporting a 95% efficacy. Efficacy is really the comparison of the people who got the vaccine compared to the people who didn't get the vaccine. Then they are basically 1/20th the risk of those who didn't get the vaccine to get the infection. So very, very low. And again, I point out that the most of the people that got sick after the vaccine got sick within the first 10 days after the very first one.
Interesting. And so that booster, I guess, really does what it's designed to do, right? To really help these patients, at least according to the studies we're seeing.
Absolutely, and that's the intent. So the other is that this is an mRNA platform, and so both vaccines are the same. So it's not that you have one and then the other one augments it in some way. The there are symptoms with the second vaccine, maybe some with the first vaccine, but certainly with the second, they're showing body aches, myalgias, maybe even low-grade fevers. But that's because your immune system has already been triggered. So when it starts to see this, what the body would view as an attack again, it's mounting its response. And your immune system is doing exactly what it's supposed to do to fight against it. That's a really good thing when we see those kinds of symptoms. And it may sound scary, but as I read from a physician who actually was in one of the first study groups, that on his 21 day, it was about a day and a half that he didn't feel real well, but he said, hey, it's better than getting COVID-19.
Yeah, of course. And
No kidding.
I'm sorry, Scott.
I was saying, I was agreeing. I was agreeing with everybody.
Okay.
Yes.
It's hard to tell sometimes. But so I'm now working in healthcare. I know that the vaccine, that first release of it is going to be primarily targeted towards healthcare workers as well as folks that live in assisted living. Now, is there like some sort of concern as far as, staggering how many healthcare workers get it at once so that everybody's not like low-grade fevering around at work the same day?
Yeah, actually, that's a really good question, Megan. And yes, we're looking at that very, very carefully. So generally speaking, especially bedside workers. So first, to answer your first question, yes, there are priorities that are being assigned in terms of who is first priority, and naturally, the bedside caregiver is highest on that list. To gird them with the armor, if you will, of protection when they're working with the COVID positive patient every day. So yes, we do have a priority behind that, and the frontline workers are the first people that are on that list. Now, second part of your question is, yes, we are trying to stagger that. Generally, a bedside caregiver they work generally 12-hour days. Not all, but generally do. And so what we're trying to do is hit them at the end of the number of days when they're going to have a couple of days off before they come back, so that they have an opportunity to recuperate prior to their return to work. Again, it's the second vaccine that we're more concerned about that. But we're really looking at, okay, how do we time this right so that the people are getting taken care of, and then they don't have to come in and try to work through that they're able to relax and do what they need to do in order to recuperate from that second vaccine.
Very interesting. And Dr. Underwood, maybe final question for you, and that is just, you mentioned that this vaccine has been developed in a unique way, certainly a fast way. It's the fastest development of a vaccine, I think, ever. And there are some folks who are maybe understandably concerned about taking a vaccine and being concerned. And I guess my question to you would be, by the time that we have enough doses to maybe get down to the level of maybe Megan or me,
no. Remember, I'm in healthcare now.
Oh, see, you may be at the front, towards the front of the line. First. Well, we'll see what happens to you. But my question is, we will be studying all these patients, right, who are going to be getting this vaccine to be able to have more data in addition to what has already been compiled and collected from the early tests to just see how effective this vaccine continues to be. And so do you have any concerns about taking the vaccine, is my short question after that long introduction.
First off, as soon as my priority level comes up, I will have my sleeve rolled up and there'll be a needle in my arm.
Gotcha. Okay.
So that's my level of concern personally. And I actually have some immune issues, medically speaking, but I still am going to get the vaccine, and I think that most people ought to be in that same ballpark. Now, a couple of parts of your question. First off, yes, this has moved along very quickly. Part of the ability for it to move along very quickly is that a number of the processes which are normally done in series have been done in parallel. So while one thing was happening, normally they wouldn't start that next phase until the one that they're in is finished, but they actually they started it at the same time so that we could see the results of things in a more rapid way. Now, that doesn't help the people who, in the results of, okay, who got vaccinated, what are the long-term effects? So the studies that were released by the FDA show an end point out from day 0 of vaccination. This is in the phase 3 trial, so this is the big group of people that got it, out to day 112. And so what's that? A little more than 3.5 months. Now, long term, we will continue to follow these folks as well as the people that will be starting to get the vaccination within the next couple of weeks all across the United States. And of course, they started vaccinating the population in the UK yesterday. So yes, we will continue to follow it. However, the other thing I want to say is a lot of concern that I've heard is this quote unquote new technology of an mRNA vaccine. So it's a messenger RNA, and you have to get into cellular structure and how proteins are made to kind of understand what the mRNA is. But we've actually been studying the mRNA platform as a potential for vaccination since the 1990s. So it's not like that is so new that we just said, hey, I have an idea. Let's take something into a lipid bilayer and implant an mRNA, which in turn will get into the cell and generate these spike proteins. But that kind of thought process happened a long time ago. It's just the new genetic sequence for the particular spike protein is the only new part of that. And the other thing that's been, remember, I told you it had to stay really, really cold. Once that mRNA is injected, it goes in and it does its job for a little bit, but then it degrades and it goes away, which is also encouraging about how the mRNA vaccine works.
Very interesting.
Very good. Well, Dr. Underwood, thank you so much for joining us this morning. As usual, we appreciate all the time that San Juan Regional Medical Center folks devote to us. We know you guys are clearly busy.
Yes, but we appreciate it.
And we appreciate being on. I have to say thank you again for helping share the message. And it's really important that we share the information with our community, and you're a key role in that. And the other thing I want to say while we're on the air is the caregivers here at the hospital and in our various clinics are working very, very long hours under very stressful conditions right now. And we cannot appreciate them enough. The effort and the willingness and the dignity in which they approach the task is humbling to be part of that team.
Very true. Well, we appreciate all the work that they are doing and that you are doing, and the team there at San Juan Regional Medical Center on the front lines, and all the information that you share with us every time you're on. So thank you so much.
Yes, sir. Thank you.